Hello, everyone. Thank you so much for joining me on this Tuesday. As always, we have a very busy show for you. We are starting on this day in northern Nigeria, in Kano specifically, the country's second largest city, where a spate of deaths that have been described as mysterious have troubled local community, as well as befuddled many who are watching the situation there, trying to understand the cause, the reason behind this rash of deaths. It's been hard to come by official word as to what is really taking place on the ground there. We're digging into it to find out what's behind it all. We're also looking at this question of lockdowns. When you look at cities, states, countries, that's largely been the way authorities have been dealing with the spread of coronavirus, to restrict movement, to shut things down. But is that the right move for Africa? My guest on today's show says absolutely not. We're going to be speaking to Alex Duval and asking why he feels so strongly that it is the wrong way to go. And finally, the show will end, as it always does, with a walk on the bright side. Our guest today is a British broadcaster, British Ghanaian broadcaster. She's also an acclaimed author. We're going to be talking about race, inclusion, and COVID, all on today's edition of Home with Isha Sesay. So much to get through. Let's get started. So if you have been keeping track of the numbers of coronavirus infections across the continent, you will have noticed that the virus does not appear to be moving as fast in Africa as it is in other places around the world. Many questions about why that is. But one thing that we all do know, we have heard directly from officials at the Africa CDC Center, is that we are not testing nearly as much as we would like. So it is hard to look at those numbers and say that they accurately or fully capture the situation on the ground in Africa at the moment. There are, however, details of hotspots emerging across the continent. One of those places is in northern Nigeria, Kano specifically, where, according to locals, large numbers of people are dying. They are telling reporters that grave diggers can barely keep up with the numbers of people that they're having to bury. A recent article in the New York Times described Kano as a place that was in the grip of an outbreak. They also said, according to the newspaper, they quote locals as saying there have been hundreds of deaths, infected doctors and nurses, which is impacting their ability to admit new patients to their local hospitals. Again, they made this point about overworked grave diggers barely able to keep up with the number of bodies they have to bury, and all of this taking place while there is a strict lockdown across the state. What exactly is happening there? What is happening in Kano? We have a guest who is there in Kano to bring us up to speed. Professor Aminu Mohammed is a pediatric surgeon, and he's a former chairman of the Kano branch of the Nigerian Medical Association, and he joins me now from there. Professor, welcome.
Thank you very much for having me.
It is so
good nice to be with you.
Thank you. Yes. It is good to have you with us. Let me get right to it, because this story of what's happening in Kano is one that a lot of people are concerned about and watching closely. There are these reports of mass deaths. You are there on the ground. Can you describe for us what you personally have been seeing and hearing?
Well, thank you, viewers. Happy meeting you. In Kano, the coronavirus comes with a boom. Unlike most of the cities that we see in Africa, where the numbers keep trickling, maybe 1, next time is 6, next time is 10. Kano started with 1, and before you say Jack Robinson, we have overtaken every other state except Lagos. Mm-hmm. So with that, once the first case of coronavirus was announced, that it was diagnosed in Kano, then a lot of people deserted the hospitals. And also even some of us, people who doesn't want to interact with us because we are working in a hospital, and we might be vehicles for the transmission of the disease. And then when something comes down hard on us, we are virtually not very ready with all what it takes to ensure that the health workers are protected, the public has the relevant information, and so on. So we have to sit down and re-strategize and restructure our services in various hospitals. And as you know, most of the private hospitals felt they are not ready, and some of them closed down, some of them scaled down drastically the services they offer, all in fear of contacting the coronavirus. So, like in our hospital, in KANO Teaching Hospital, we have to separate the emergency into three. We have four. We have the medical emergency. We took it to a different place. Surgical emergencies were taken to a different place. Pediatric emergencies were taken to another place. And then a fresh new area that we called holding area, where people, when they are triaged, they will be directed. So this will avoid or reduce the congestion at the entry points of the emergency. And
so let me
to go back, yes.
I just want to jump in at that point, because as you talk about your hospital, the KANO Teaching Hospital, it's one of the places that was referred to in that New York Times article, where they say, even before it was officially designated that KANO had this problem with COVID-19, they were seeing large numbers of elderly people coming in with trouble breathing and just conditions or symptoms that are in accordance with COVID-19. Did you see these patients come in? Did you see an increase in elderly people coming into the hospital, you yourself?
Yes, there was an increase in the number of especially people from 55 and above, and especially most of them are previously patient clients of the hospital that were coming for other comorbidities, most especially diabetes, hypertension, and other chronic obstructive airway diseases. But what we discovered in common are that these people are desaturating, unlike the way we see them coming to our emergencies before. So with that, even before the diagnosis of the index case, we started getting concern that probably COVID is already in the city and probably community transmission has started. But unfortunately, at that time, we have not started testing in KANO. So it will be difficult. Some of these patients, when you take the test and it was taken to the Federal Capital Territory, it will take about 2, 3, 4 days before it comes back. And before then, some of these patients have already demised. So these are some of the problems that we discover. On the other aspects of increasing deaths from the community, the concerns of the grave diggers and so on, yes, definitely there was significant increase in mortality in the city, unlike what we used to see pre-COVID era. And what we discovered are that some patients may have symptoms that may be related to COVID, but they are undiagnosed. And some patients were not having symptoms related to COVID, but other comorbidities that these patients have. And unfortunately, people have phobia in coming to the hospital. People have phobia in going to the healthcare personnel. And some of them, because of the duration it has taken for the lockdown, 5, 6 weeks, some of them, their drugs that they are taking have finished. And so these were some of the reasons why there was an increase in morbidity and mortality in the city. So yes.
No, so I just want to ask, now that you are very clear on the fact that COVID is there in KANO, what is the situation with testing?
Testing, especially, even if you look at it, the way we look at it is that we have grossly insufficient testing in the country as a whole, because we have like less than 2 people per 1,000, or less than about just 0.2% of the total population of Nigeria were actually tested for these 2 to 3 months that we had COVID in the country. And then likewise, if you come to Kano in particular, initially we don't have a single center, but now we have 3 centers for testing COVID. Their capacity is about 300 samples. But if you look at it, it's not only testing Kano samples. All the states around Kano, Jigawa, Katsina, Zamfara, sometimes even Sokoto, Bauchi and Co. do come to Kano to have their tests done in the same facility.
What about contact tracing?
Is
Professor, can you hear me?
Contact tracing, we have can you hear me?
I can. Let's see if we can clean up your audio. It's just getting a little mangled. But try again. So you're just saying that, just so I'm clear, that let me ask a question. See, you were saying that in Kano, your lab or your testing facility is taking in samples not just from Kano but from other states. So clearly, there's a situation there of insufficient testing in Kano itself. What about contact tracing?
Yes, contact tracing now has significantly improved, in the sense that now the committee has decentralized. They have local government coordinators. You know, Kano is a vast state. We have 44 local governments. We have coordinators in every local government, and then they are trying to decentralize to different electoral wards, so that these patients can be tested, and then those who have the disease can be isolated. But the problem is that after the significant rise in the number of cases in Kano, we now have over 800 cases in Kano, and then the isolation centers are mainly accommodating about 600. So that's another situation that we have.
So 600 people in your isolation centers?
We have capacity for isolation centers of 600, okay. But we have about 800 cases, over 800 cases in Kano. So you can now see that that is also overwhelmed. So our association now went around to all the health facilities, not only in the Kano city, but in the major general hospitals, to assess their capacity. And also with that, we now use that assessment and data to advise the government. And then a lot of other alternative isolation centers are being opened up in order to cater for the populace. So there is adequate contact tracing, but if you trace and you made a diagnosis of a positive COVID, then you have to also scout for a place where you will admit and isolate these patients. Yeah. So now we have started strategizing, dividing this COVID into, there are 3 major groups. People with no symptoms or very mild symptoms, and then people with moderate symptoms and severe symptoms. So with that, we have also stratified the isolation centers, so that this will cater for severe symptoms, those will cater for moderate symptoms, and those that will cater for the mild symptoms, so that we will increase the bed capacity. And the good aspect of it is that we are also discharging other people who have gotten well. And with that, that is also creating more space for others that are being diagnosed now.
Let me just ask you very quickly, because I am out of time, but Professor Mohammed, do you feel the situation is under control there in Kano? Because what the picture you're painting is one of huge concern. You know, inadequate space to take in new patients, the sense that there's widespread community transmission. I mean, have you guys got the situation under control there?
Yes, just like what I told you, we have significantly improved from where we started. And so the main thing now is that there is still significant room for improvement, whereby the health workers need more PPEs and more other consumables that these patients require. And then also we need more isolation centers, which the government is making a lot of effort to open newer isolation centers that can accommodate more people, so that with that we shall be towards plateauing the curve in KANO, because the contact tracing is quite aggressive. Mm-hmm. And the diagnosis, those that are diagnosed are being isolated. So the issue is that, you know, we are a third world country or low and middle income country. So therefore, our capacity may not be as in the high income countries where they actually have everything. Even them have some compromise.
Even the countries here, I'm sitting in America, and they don't have everything.
Yes, and the main problem is that sometimes, even if you have some people, philanthropists who want to buy some of these things, but occasionally they don't even have where to. So these are some of our problems.
Yeah. Professor Mohammed, I'm so grateful for you joining us to really give us an on-the-ground view of what is happening there in KANO. We're going to be checking in with you regularly to see how things are going, to see if this improvement is happening fast enough. But till then, please take care. And we really appreciate your insight and perspective. Thank you.
Thank you very much. I appreciate everyone.
Thank you. Be safe. Take care.
Thank you very much.
Professor Mohammed there in KANO, actually at one of the main hospitals. He's at the KANO teaching hospital, where they saw an uptick in elderly patients coming in some weeks ago, all of them manifesting symptoms of COVID. And he himself said that basically they don't have enough space currently to isolate people who they find in the community and suspect of having COVID. They need to test more, but he did say that they're working on it. They're working on getting more PPEs, or working on getting more isolation center space. And he seemed to feel that the situation is well, he didn't say it wasn't under control. Let's put it that way. We're going to continue to follow the situation there, because he did say that they have capacity for 600 people in the isolation centers, but they have about 800 cases. So clearly, there's a capacity issue. We'll be watching it closely. Moving on, let's get you up to speed quickly with the spread of coronavirus across the continent, and let's bring you the big picture and then bring you total number of cases in Africa now. Let's put those numbers up on the screen. Currently, over 88,000. I hope that sound isn't bothering you as it's bleeding through in my ear. 88,674. Total active cases, 51,698. Total deaths, as you see there, 2,841. Let's drill down for a regional view, starting with Northern Africa, looking at Egypt, which is still the most impacted country. Confirmed cases, 12,764. And in terms of recorded deaths, 645. And in Algeria, the other country in Northern Africa that you should make note of, authorities there have made mask wearing compulsory. 7,201 cases there. In terms of deaths, 555. Let's go down to Central Africa. Cameroon, the most impacted country. The country has 3,529 confirmed cases. Look at those deaths, 100, 140. We're also watching DRC. The numbers there continue to tick upwards. Confirmed cases there, 1,538. Deaths, 61. To West Africa, you just heard about the situation in northern Nigeria in KANO. We've just told you the situation there. In the south, authorities have paused efforts to relax the lockdown restrictions. They'd been kind of lifting those. They've now paused that effort. And that means that airports, land borders, schools, parks, and places of worship remain closed. The nationwide curfew in Nigeria remains in place from 8 p.m. to 6 a.m. Reason for all of that? Well, look at that number. That tells you why. 6,175 cases in Nigeria, number of deaths approaching 200, 191. Let's talk about Sierra Leone, my own country. 519 cases. Number of deaths, 33. Remember that there's sometimes a lag between the reporting of these numbers to Johns Hopkins University, which is where we are taking the numbers. Sometimes there's a lag in country and then being reported to institutions. But at last check, when we looked, the number for Sierra Leone, 519, number of deaths, 33. Liberia, we had the former president on the show yesterday, Ellen Johnson Sirleaf. They have 233 cases, 23 deaths. But look at Guinea. Guinea is a source of huge concern when you look at that corner. 2,796 cases, 16 deaths. Sierra Leone there, out of the 3 countries with the highest number of deaths, which is of great concern, I know, to many in country right now. Shifting to East Africa now. Sudan, the most impacted country there. Confirmed cases 2,591 in Sudan, 105 recorded deaths. The authorities in Sudan have extended the lockdown in Khartoum by 2 weeks ahead of Eid, the end of Ramadan, when traditionally large groups of people would gather. In neighboring South Sudan, the country's vice president, Riek Machar, and his wife, who is the defense minister, Angelina Teny, a number of their bodyguards and staff members have all tested positive for coronavirus. Machar says he has no symptoms but will quarantine for 14 days. Total confirmed cases in South Sudan, 290 and 4 deaths. Let's talk about Tanzania, shall we? We talk about Tanzania every day on the show. More head-scratching decisions. That's the best way of describing what's happening in Tanzania right now. No update on cases since April 29th. If you've been watching the show, you know that. The U.S. Embassy has warned of the potential for an exponential increase in cases there. That is a claim that the Tanzanian government is rejecting. But the headline out of Tanzania, the government is now saying that all foreign visitors will no longer be required to go into a 14-day quarantine upon arrival. They'll no longer go into quarantine. They'll just be asked about symptoms for COVID instead. Confirmed cases in Tanzania. Remember, these numbers are useless because the last time we got numbers from Tanzania was April 29th. But be that as it may, let me give you the numbers as last reported. 509 cases in Tanzania, and when you look at the number of deaths, 21. Let's finish up in the southern half of the continent, South Africa. South Africa continues to surge forward. If you're watching the show yesterday, it was over 15,000 cases. Then look at the numbers today. 16,433 cases in South Africa. They lead the way in terms of case numbers in Africa. 16,433 in South Africa, 286 deaths. A check of coronavirus numbers across the continent for you. All right. We want to go back to West Africa and talk about the situation there as they battle coronavirus. We had Ellen Johnson Sirleaf on the show yesterday, and she talked about the lessons learned from battling Ebola back in 2014. She said there are many lessons that could be taken from that outbreak and applied to the response against this pandemic. We want to dive deeper into this issue of lessons learned and what we can take from that outbreak and help make the response to this pandemic more robust. My next guest is Dr. Jay Soka-Moses. He was on the front lines there in Liberia. Apologies for the sound bleed there. There's an echo. He was on the front lines in Monrovia. Okay, we're having a little audio issue. Sometimes you just get those days. He was there on the front lines in Monrovia in 2014, working at a treatment facility, and he is still working in the space of patient recovery. He's now an advocate for an enlightened global approach to pandemic prevention and response. He joins us now. Dr. Moses, welcome. Can you hear me?
I can hear you very clear.
Oh, that's wonderful. Welcome to the show.
Thank you very much for having me.
It is very good to have you with us. You were on the front lines during Ebola in 2014. You are there in Monrovia now. You are seeing a different situation play out. As you look at the situation today, what are the parallels? What are the similarities between what played out in 2014 and what's happening now in 2020 and coronavirus pandemic?
Thank you very much. The two diseases are very different. However, there are many similarities. One of the similarities is the mistrust from the community. That's one of the similarities. The panic is the same. And then the other thing is the misinformation, the rumor, the anxiety on the street. They're all still there. That's one of the similarities. These are some of the similarities between Ebola and what's happening now. There are many differences. The differences is that now community members are more aware, and because they're more aware, that does not help them prepare much better because the mistrust is still a lot in the communities. In addition to that, there's still a lot of panic. But the difference now is this one is transmitted so quickly. It's so virulent, it's so easy to be transmitted that even getting to the communities, there's so much risk for response teams. You cannot send contact tracers in the community to be as free as they really want to, because they themselves, they are at risk of becoming infected, and also their family members becoming infected. So that is a very big difference. The other big difference between Ebola and COVID is, yes.
No, go ahead. I'm sorry. I thought you were pausing because we've just lost your picture. I just want to let our viewers know that we lost your picture, but please keep going. The other big difference.
The other big difference is that now we have to do this on our own with very little support. The World Health Organization is on the ground. The U.S. Center for Disease Control is on the ground. The U.S. NIH is here getting ready to roll out research. However, in 2014, we had a huge global response to the outbreak in West Africa. With the European CDC, you had the African Union, the West African Health Organization, the U.S. military. So there was a huge presence on the ground, everybody working together to contain and end the outbreak on the continent. There was a lot of support. All of that support is not present today. But what's really the good news is that team members are more prepared, they're aware. There were a lot of lessons learned from Ebola, and a lot of these lessons are still applicable in this outbreak, and it's really, really helping.
What is the one major action you feel needs to be taken to certainly strengthen the response currently? You mentioned the question of misinformation, of panic, of fear, of contact tracers being unable to move freely in the communities because of fear of infection themselves. You have been working in the space now looking for an enlightened global approach to pandemic response. What's the one thing am I right? so much for joining this day. Right, so we had some trouble with his audio, and as you noticed, his picture disappeared while he was speaking. So apologies for that. Again, we want to persevere with these conversations, sometimes even when the audio isn't the best, because we also understand that, you know, depending on where you are in the world, sometimes the bandwidth sometimes isn't what we'd wish for, but we have to persevere because this information is important and we need to get it out. So that's what we did with Dr. Moses there. We will get him back for another conversation in the days ahead. Very quickly, lots of people writing in to tell me that it's poor connection. So we understand that. They say my audio is poor as well, which is troubling. We're not having a good day in terms of our technical setup. We're going to keep persevering. We're working behind the scenes to clean it up. Let me see. Can you guys hear me? Let me see. Because right now I have a lot of messages coming through just telling me that you can't hear me. Technology problem from Suma Abdullahi. Martha Sesay says the same thing. Kadi Mansaray, Margaret Moiba. Liberia doesn't have good network, is what Adije Victor David had to say. Marie Salim, everybody's saying that there's poor connection. But let me see. I'm going to keep going. Write in and let me know if you can hear, because I don't know whether in our control room they can tell me what audio is like. Let me see what is happening. Somebody give me some guidance in terms of audio. Okay, Margaret Moiba says, everyone, okay, I'm getting word from the team saying they can hear me clearly now. Thank you, everybody, thank you. This is a team effort. I do the show so we can do this together, which is what we're doing today. So thank you. But in case you missed what Dr. Moses said, let me recap very quickly for you. He was on the front lines of the Ebola outbreak back in 2014. He says the similarities that exist between and would be tested. Get it, but we'll do that in the days ahead. Let's move on. Now they're saying poor connection again. All right. Well, we're going to persevere. I want to move on and I want to move on and talk about the way this crisis is impacting everyone, but impacting people differently. So the impact of this pandemic on men versus women is different in many parts of the world. Certainly the social inequities and gender disparities that exist in many places. I'm just checking audio. Zaina Bangura, thank you, says she can hear me now. Thank you for that. Thank you for keeping me honest, everybody. We're doing this together, so keep letting me know what you hear. So yes, in various parts of the world, the social inequities and the global disparities are being amplified, they're being magnified by the glare of this pandemic. And for women, that is very troubling, particularly as a lot of women are most likely to be healthcare workers and they have a more fragile socioeconomic status. All of this creates a very difficult situation for women in places, particularly in Africa, to navigate their way out of this crisis. I want to talk more specifically about what women are facing. I want to bring in Vanessa Munga. She's the Director for Gender, Women and Civil Society at the African Development Bank, where she leads the bank strategy on gender equality, women's empowerment and civil society engagement. And she joins us now from Abidjan. Vanessa, at long last.
Hi, Aisha.
Hi, how are you?
Very good, thank you, and good to be with you.
Very good to have you with us. And forgive the technical difficulties. Some days it is just like that, but we persevere. Talk to me about the picture emerging of women in this crisis and how they are being uniquely affected by this pandemic.
I think what's really interesting in this particular pandemic is that for the first time in a really long time, the world as a whole is facing the same problem. And people are crying their loved ones for the same reasons, from Africa to Asia to America to Europe. And so it reminds us of our interconnectedness and our joint vulnerability. However, the impact is different on people. And as you were saying, from already at the global level, you can see that although Africa for now has been a little bit less hit, it seems, as of today, in terms of a sanitary impact, we can already see a dramatic socioeconomic impact on the continent. And it's going to hit the most vulnerable the most, as always. So people living in fragile contexts, people living in refugee camps, internally displaced people, and the more marginalized groups in general. Because we have economies that can only be directly impacted, particularly by the confinement measures. And you were talking about women in particular. Women are mostly employed in the trade, service, and commerce sectors. They also dominate all the cross-border trade, informal trade. And when you look at it, when you close borders, that's having a direct impact on their livelihoods. And actually about 40-something% of African people rely on that cross-border trade for their livelihoods. And these are people that live from one day to the other. So that's how people are going to be impacted economically. It's just an example. And obviously women and the poor will be more hit than anybody else. But women are also at the forefront of the crisis. As you mentioned, they make up the majority of the healthcare workforce. I think we have up to 90% in many of our countries. They are also most often in fragile socioeconomic situations, particularly in terms of access to economic opportunity. So they work in the informal sector. They're more likely to live under what we call the level of poverty, which is under $2 a day. And we know that this crisis will push more people in that poverty trap. Women also have an increased burden at home, and we also know that there's an increase in the number of gender-based violence cases. So that's how women are impacted differently, but I think they're also part of the response that can be different, and that's where I get a lot of hope from.
And I was going to say that just to further illuminate the impact here, that the impact on women has an impact on children and health outcomes and education standards and ultimately the SDGs, the Sustainable Development Goals. All of this impact as it hits women has a ripple effect, a secondary and tertiary impact on what happens down the line. What are you doing? Knowing all of this is one thing, responding to it is another. How are you shaping a gendered response to this crisis?
Well, there's always two sides of the things, because particularly in the African context, it's always making sure that it's not about targeting women, supporting women to the expense of men. It's about correcting the imbalances and ensuring that everybody has a fair shot and fair access to everything, from access to basic social services to economic opportunity. So from the African Development Bank perspective, since the crisis hit, we've been rearranging our entire work program and, focusing on supporting the countries. We've put in place a 10 billion euro fund to help them with the liquidity that is necessary to be able to respond in the short term and provide essential services and meet their obligations to the private sector. And so part of our job of my team is ensuring that all of this actually integrates a gender lens and that women's specific needs are taken into account in the response. But I think we're also already thinking about the tomorrow, the recovery. And a large part of the response will be economic response and how to ensure that women have access to the economic opportunity and the tools and the finance in order to be part of the solution. Because as you said, when they're economically empowered, the ripple effects on the community are huge. Our research shows that they reinvest 90% of their revenue in the education, nutrition, and health of their families. So in terms of, returns on investment, development outcomes, these are the best places to invest.
But this question of access to the tools to recovery, that has often been a sticking point, a problem for women on the continent. How do you ensure that is overcome this time and that women don't get left behind or further behind?
So we really need to change the way we do things. People keep talking about, what is the new normal? How are we going to rebuild differently? And I think we need to very, very deliberately tackle inequalities. because that's the only way, keeping doing the same thing and expecting a different result at the next crisis is pure madness. Yeah. So how do we do things differently? And we know that on the continent, women are a huge economic engine. They already are the backbones of our economies. They dominate the informal sector, the trade, the commerce, the services, the agriculture. But they are marginalized in terms of access to productive resources. Finance, they're perceived as riskier because there's less information. They don't always have collateral. We have countries where they cannot open a bank account without authorization of their husband or their father. So these are some of the structural challenges that right now are preventing their economic participation, in addition to less access to training and information. Mm-hmm. So we are trying to do our humble part by mobilizing all actors, and this year we'll be rolling out a major program on access to finance for women across the continent, which is the largest ever in the continent's history in terms of access to finance, but that won't be enough. Everything needs to change. All actors need to start behaving differently. We cannot have programs only for women. We just need to make sure that all of our programs take everybody in society into account.
Yeah, absolutely. Vanessa Munga, it's so good to speak to you. Thank you so much for your insight. We'll check back in to hear how the rollout goes and get some more data on the situation. Thank you, Vanessa. Be safe.
Thank you, you too.
Okay. Let's talk about the response to this pandemic across the continent. Africa has followed the lead, or I don't know if it's a case of following the lead, or certainly done the same things a number of countries around the world, which is to shut down much of their borders, shut down and restrict movements, and essentially use that as a principal mechanism for curbing the spread of coronavirus. My next guest says that's the wrong approach to take, that we should be looking at the situation specifically through the lens of what the local conditions are, what community needs and is asking for. Let's get his perspective on or his thoughts on a better way of handling this pandemic. Alex Duval joins me now from Boston. He wrote a piece alongside Paul Richards that appeared on BBC.com and joins us now to talk a little bit more about it. Alex, welcome.
It's a pleasure to be with you.
Lovely to have you with us. You have said very clearly and unequivocally that lockdowns should not be the de facto approach taken by African governments in dealing with this pandemic. Can you explain why you feel it's the wrong move for Africa?
Well, the first question to ask about a lockdown is, what is it for? Now, in the case of China and some of the East Asian countries, they had the capacity there to completely shut down entire cities and to bring out hundreds of thousands of people to police that shutdown. And then as they began to lift, to trace the contacts of every single person who was found to be infected. That can only be done in extraordinarily well-controlled societies. Mm-hmm. And those possibly don't exist anywhere in Africa, and if they do, very, very rare. In Europe, the strategy was, let's flatten the curve. And I live in Boston. Boston is a city with perhaps some of the best health infrastructure anywhere in the world. And Boston struggled. It managed, but it struggled to cope with the big surge in cases. And the expectation in Boston is that when they lift the restrictions, and they're just beginning to restrict them now, there will be more cases coming in, but the Boston hospitals that, as I said, are extremely well developed, will manage those surging cases. Now, where in Africa do we have that capacity? So the biomedical and the population control approaches simply aren't going to work. They're not an option in Africa. But Africa has one big advantage compared to China or to Europe or the United States. Africa has actually experienced and come through major epidemics in the recent past. HIV and AIDS, Ebola are two examples. How did Africa get on top of those? It was through ordinary people changing their behavior. The very intimate behaviors, sexual behavior in the case of HIV, funerals and handling, interpersonal contacts and washing bodies and so on in the case of Ebola. And in the case of COVID, it is how you interact on a day-to-day basis with your family and your neighbors. And there is no way that any government can either know exactly what these behaviors are and tell people to stop them or enforce them. Certainly not in the African context. It's only the communities that can do that. And what we know from these other cases is that communities are very literate. They're very able to respond. They understand how these diseases spread. And they can take the lead. The communities are the ones that will tell us how they can get on top of this.
So talk to me about in past outbreaks. I know you worked very closely in the AIDS epidemic. You know Africa well and have followed everything that's played out there in terms of these responses. Give me some specific examples of workarounds that were generated in the community to deal with or to counter top-down directives or guidance.
Well, what was very interesting about HIV/AIDS in Africa is that all the predictions were that the rates would just go up and up and up and up, because those who were doing the modeling, the epidemiological experts, didn't take into account the fact that young women in particular would become more aware of how HIV is spread and would begin to become more proactive in saying, I'm not going to get infected by this. I'm going to take the steps necessary to protect myself. And it was really a grassroots, particularly women-led set of initiatives across the continent that brought the rates of HIV down, while the authorities really struggled. And all the epidemiologists, the public health experts, when they go back and look at HIV and AIDS, when they go back and look at Ebola, and they say, hey, this didn't follow what we expected. And what explains the success in overcoming these epidemics is that people changed. Now, if you take what is needed to change in the case of COVID-19, people need to find ways of shielding the most vulnerable and slowing down the spread among the general population. And so where does it get spread? For example, it gets spread in markets. Yeah. How do we manage a market so that people can still go to the market, but will still maintain a bit of social distancing? Should we have polystyrene sheeting in front of the stalls so that those who are selling fruits and vegetables have some plastic sheet to protect those on the other side? How do we protect the most vulnerable, the elderly people? Now, again, it comes down to women, because these are multi-generational households. And who is it who cares for the elderly? It's the women. So if we have ways, for example, of saying, if instead of shutting down societies, governments were to say, okay, you have a lot of elderly people, not as many as, let's say, in Italy or in China, but let's find a way of shielding the elderly. Send them to the village. Put them in places where they can be a little bit isolated, but also cared for. Let's find a way of caring for these at-risk people to get them through the crisis, so that the young people who are not really at risk can maybe build up immunity, and then we can begin to return to normal. So,
Alex, a great question posed by one of our viewers, and that's why we love doing this show, because they can be part of the conversation. Bev Archibald says, what about people who are asymptomatic? People walking around infecting people and not knowing. You can only do this with a lockdown. Thank you, Bev, for that question.
It's true, but how long are you going to maintain this lockdown for, and at what cost? If we accept that the virus is already in Africa and that it's going to spread, now we would rather not accept that reality, but it is a reality. Then, if the virus is circulating, and the great majority of African young people are young and relatively healthy, and there are only certain groups that are at high risk: people who have tuberculosis or have recovered from it, maybe people who are HIV positive, and the elderly. Let us find a way of accepting that this virus is circulating, protecting those. So it's not ideal. There is no perfect solution to this, but let's not allow seeking the perfect solution to be the enemy of finding the workable solution for every particular society.
Alex, well, so interesting to hear your perspective. Thank you so much. Obviously, this outbreak in Africa is really kind of at the beginning. We're lagging behind the rest of the world by several weeks, so there will be much to talk about in the days ahead, and I hope you'll come back and continue the conversation.
Yes.
Thank you. Please take care in Boston.
Yes.
Thank you. Fascinating insight there from Alex, making the point that as he sees it, lockdowns are just not the answer because they most times don't involve the community helping shape the response, and they're difficult to keep in place because of the economic burden it places on people who need to get out every day and make a living, and that just generally that it's unworkable is how he sees it, and says that there are better ways. Let the communities generate their responses. Talked about HIV/AIDS and the epidemic there. In Africa, what we saw was young women, grassroots activism, reshaping the response. You heard him also talk about markets, ways maybe we could be redoing our markets. Just interesting perspectives for us to consider and look at in terms of shaping our own local responses. I think the one thing that we can all agree on is that we should be looking at our own local conditions as we shape the response to this pandemic. We have to look at what we are dealing with within our own specific contexts, and then work out how we respond. And I think that much is true. So thank you very much for the comments, Bev. Really appreciated that question because I think it's a good one. What about the asymptomatic people who are walking around and show no signs of illness? Very, very important point to make there, and one that I'm glad we got to share. Let me do a very quick run through some of your other comments as they come in. Alhaji Amara Kabe says, I think this is the time women have to take their rightful place in society. Women should no longer accept the gender disparity, which is clearly to their disadvantage. Women offer more to society than men, hence they should finally benefit. Alhaji, thank you for that comment. Going back to the conversation with Vanessa Munga from ADB and talking about increasing access for women to capital, to opportunity, to close the gaps that exists socioeconomically in many places around the world, one which we're very concerned about in Africa as the slowdown happens. Looking at some other comments that are coming in, Morris Nass says, it's refreshing to hear someone that has a better insight of Africa to offer a perspective about, referring to the interview with Alex there. Listen, we want to get as many different perspectives on the show every day. So please keep coming back. We're going to be bringing more thinkers from around the world, from the continent and beyond, to help share their thoughts on how we move forward. Julia Ketter says, social interaction needs to stop. More education on this virus is important for our nation in Africa. How can we protect our people who do not have access to media, communication systems, and so on? Julia Ketter, that again, this question of communication and how we communicate the threat of coronavirus to local populations is one that we talk about a lot on this show. Some of the things people have said, we need to be moving away from mass communication, and it should be songs, it should be artwork, it should be plays, it should be a mode of communication that you can take directly to the community, that they can directly engage with. But very much so, very much the idea being we need to tailor the message for those we are speaking to, that we can't just keep it up here, that we need to find ways to make sure that everyone at every level can access the important information. Patrick says, distribute free masks in Nigeria. Certainly that is underway in Uganda. They have just made it known that they're going to be distributing free masks. Algeria has made mask wearing compulsory. More places stepping up the calls to wear masks and to wear them in public. Mamadou Sow, women make up to more than 70% of health respondents in Africa. They are first line of defense. They are indeed, Mamadou, and I know you know this well, working with ICRC. You know very much how we need to protect the women and how they have to be involved in shaping the response. Morris Nass, it's my first time on your stream. However, I'm really impressed by Alex's viewpoints about Africa. Well, thank you, Morris. I hope you will keep coming back every day, because we are here every day bringing you the very latest on the COVID pandemic in Africa. So we want to very quickly take a check of the numbers again, and just let you know what's happening very, very quickly before we go. In fact, rather than that, let me tell you the 5 stories that I'm watching closely. very quickly. I'm watching 5 stories in the hours ahead, and I want to tell you what those are. Watching that situation in KANO, where despite the fact that there's a strict lockdown in place, they will be allowing Friday and Eid prayers. These are the prayers that mark the end of the holy month of Ramadan. They are going to be taking place even though the numbers continue to go up in KANO, but we're hearing that the governor there agreed to these prayers going ahead after he spent some time consulting with local Islamic scholars. So that is what happened there in KANO, that they will be allowing Friday prayers and Eid prayers. Also want to tell you about the situation in Kenya, where numbers continue to go up, but their health minister told the World Health Assembly that they are making progress against the disease. We continue to watch that situation closely in Kenya to see whether they have indeed got the situation under control. They are facing criticism there in Kenya for the imposition of lockdowns and restrictions on movement. Again, their local medical association, doctors there, saying it's not the right move for Kenya, that they haven't followed any science or data to shape their response to imposing a lockdown in Kenya, which kind of goes back to what we were talking about with Alex. The other story that we're watching, story number 3, Ghana. The opposition in Ghana is questioning government data, specifically the numbers of recovered patients. At present, Ghana has 5,918 confirmed cases of coronavirus and 31 deaths. As the numbers increase, the Ghanaian government has put out data of over 1,000 recoveries in 2 days. An aide to the former president, John Mahama, who's also the head of the opposition, one of the opposition parties, that aide posted on social media questions about those numbers for recovered patients, taking some heat for raising those questions, but the Ghanaian government is yet to provide an explanation for this surge of 1,000 recovered patients in some 2 days. Botswana, another story we're watching closely for you. The president of Botswana has headed off to a regional bloc meeting, the Southern African Development Community meeting that was taking place in Harare, Zimbabwe. He jetted off Tuesday morning for this meeting that we're told he was made to understand, or certainly believed he had to attend in person. But the downside to attending that meeting in person is that when he returns to Botswana on Tuesday night, he has to go into quarantine for the 3rd time. So Botswana's president has been in quarantine twice before. The first time in March when he attended an event in Namibia, the second time when he went to Parliament and a parliamentary health worker was found to be positive for coronavirus. And the 3rd time, which would be Tuesday, he's going into quarantine for a 3rd time for 14 days after going to the SADC meeting in Harare. Final story that we are watching for you, Idris Elba will be hosting a massive Africa Day concert on May the 25th, a concert to celebrate the continent, to also draw attention to the pandemic and what's happening. He will be hosting this with a host of African stars. It will be on YouTube in support of MTV Base, or courtesy of MTV Base Africa. He'll have everyone involved, Burna Boy, Yemi Alade, Tiwa Savage, everyone will be there celebrating the continent, drawing attention to what we're dealing with right now, trying to raise awareness and support for our efforts. So that is the situation there with the 5 stories that we're watching closely for you, and we'll bring you updates in the days ahead. Almost at the end of the show, and we always like to end that on the bright side, leave you with some hope, some inspiration, some joy. Today's bright side is she's actually, I guess, she's actually royalty, I guess, or she's certainly part of high society. TV broadcaster June Sarpong will be joining me shortly over on Instagram. She has built a career and a reputation for tackling issues of diversity and inclusion, and we caught up with her a little bit earlier, and here's what she had to say. Okay, although we don't have the sound, as I'm being told, but she will be joining me shortly on Instagram. Sometimes you just have those days. She's going to be joining us over on Instagram at the top of the hour, which is now, to talk all about her work and the fact that she got made an OBE, an Order of the British Empire. I think that was last year or so. We're going to be talking all about June's career, the fight she's engaged in now to make British media more inclusive and more diverse, and just get her thoughts on how she is coping with life in quarantine and these strange times we are living in. So we'll be talking to June over on Instagram in a couple of minutes. Do hop over there and hang out with us there. That does it for today's edition of Home with Isha Sesay. Whether you're watching us on Facebook, Twitter, or YouTube, I hope you've enjoyed the hour. Meet us back here tomorrow. Tomorrow, which is Wednesday, we do a slightly different show. It's called a Deep Dive Wednesday, and on Wednesdays we have one guest and we tackle the subject in depth. We ask you to send your questions so that you can be part of the conversation. So it's an hour-long deep dive. Tomorrow it is Musa Malanga. He's a cell biologist. Check out his TED Talk. Fascinating. He will be joining us to talk about COVID-19, what this virus is doing, how it impacts the body, how it's moving through populations, and what scientists need to be doing now, and specifically the role of African scientists and why we should be looking more closely at Africa as we battle this pandemic. Musa Malanga will be here for Deep Dive Wednesday tomorrow, same time as usual, but slightly different show. Today, that's it. See you back here, same time, same place. If you've got a little more juice in the tank, meet me over on Instagram. I'll be there with June talking about life and surviving quarantine. Take care, everyone. Stay safe. See you back here tomorrow. Bye for now.